Hi guys, good evening. Hope you had a great day. So I'm Dr. Krishna Priya. I'm an orthodontist and I'm a part of this core team in covering the syllabus for orthodontics for the NEET MDS program. So for the past 2 days, we've been talking more about anchorage. What are the different types of anchorage and how we can use the anchorage and factors involved in it. And then we were talking about habits, what all the habits and how to overcome it. So today we are going to have a continuation on the habits part and followed by the space maintenance part. So if you have any question after completing a particular topic, kindly put up in your comments so that I can address it whenever needed. And if you have any questions regarding anything later, kindly uh, text me or put a comment onto the video so that I can address whenever needed. So with that in mind, let's go to today's session. Okay. So today we are going to cover about 38 questions. So let's start. Newborn infants are obligatory oral breathers, obligatory nasal breathers, predominantly oral breathers, and nasal and oral breathers. So the key word here is mainly obligatory. Okay? Obligatory in the sense that they prefer that over the other, and they are more convenient towards the um, given condition. So newborn infants are always obligatory nasal breathers. Yes. Why is that? Because in a newborn child, they do not have sufficient masticatory force or sufficient muscular development for them to breathe through their oral cavity. So they mostly rely on their nasal cavity and nasal area for their breathing. And this function will also help in improving their form. Form is the nasal cavity and associated part of it. So whenever they use that muscle or use that area to breathe in and breathe out, it will also develop the nasal cavity much more. So it is very important for them for their growth as well. So usually infants, the key word here is infants in the question and obligatory in the MCQs given. So only for infants they are obligatory nasal breathers. I think with this I've given a clear cut idea about the question and answer. See, newborn infants have small nasal passages and therefore their nasal breathing may be further compromised by nasal congestion. Sometimes they have some congestion in their nasal cavity, right? Like mucus accumulations and other infection. Therefore, it's very important to keep their nasal tract free of any congestion and be very clear. And they're not capable of oral breathing, as I said earlier, because of the necessary nervous muscle coordination and also the muscular intervention. As infants grow and develop, gradually they transition from an obligatory nasal breathing to a combination of nasal and oral breathing. So at the age of 6 months, most infants are capable of breathing through their mouth if needed. So here when they ask the question as infants, you have to obviously choose the answer obligatory nasal breathers. But when it comes to a 6-month-old child, it can definitely breathe through both their nose and their mouth. So the answer should be different. So going to the next question, one of the following is a reliable means of quantifying the extent of mouth breathing. So whenever we breathe through the mouth, we must analyze how much we breathe through the mouth in order to identify the cause and also to calculate the action. So cephalometry, butterfly or cotton test, water holding test, and rhinomanometry. So these are the 4 steps they have given. So first is cephalometry. Cephalometry is a radiographic analysis with which obviously we can quantify it with the nasal pathway. We can just quantify how much of airway is present in the upper and lower pharyngeal region. Second is butterfly or cotton test. It's nothing but placing a cotton here above the upper lip and finding out whether they are breathing through their nose or mouth. Okay. Water holding test. We have to just ask the patient to take a cup full of water and hold it in their mouth for about 20 seconds or more. If they can't hold it more than 20 seconds, then they do have mouth breathing. Rhinomanometry is an instrument which is used to measure the amount of mouth breathing or the severity of mouth breathing the patient has. So with this, I think you will know the answer. That is rhinomanometry. So this is the device. It is incorporated in such a way that we understand how much of a severity is the patient having with respect to the mouth breathing. It is measured. Yes. So it involves inserting a small tube in the nostril and measuring the resistance to airflow as the patient breathes through their nose. How much resistance is present? So in case of mouth breathing, the nasal passages may be partially or completely obstructed, leading to the decreased airflow resistance through the nose. So this rhinomanometry, it involves both the nose and the mouth so that to identify in which area the resistance to the airflow is low. So objectively speaking, it also provides us a quantitative measurement. So for the given question, this will be the right answer. So cephalogram also provides a quantitative measurement, but in order to evaluate it, we need to undergo a radiographic diagnostic aid for the patient, which is generally not preferred if the patient comes only for mouth bleeding. Yes. I think we've discussed this. So rhinomanometry is the right answer for this question. The snort test is associated with the assessment of TMJ dysfunction, breathing pattern, velopalato-pharyngeal insufficiency, and skeletal dysplasia. So, whenever you have a question with an anagram or some test and you don't have any idea of what it is, always go and associate it with a common general word. Usually, all these test name will be associated with commonly what we call the particular disease. In this case, even if you don't know what snort is, snort is generally associated with something that a pig does during its breathing pattern, right? So, with that in mind, you can associate with a breathing pattern, which is one of the option here. So TMJ dysfunction is not related at all. Velopalato-pharyngeal insufficiency is totally different, and it is not associated with skeletal dysplasia. Snort is nothing but simultaneous nasal oral respirometric technique. Okay, it is given by Girdley and Wick because it enabled a simultaneous measurement of inspired and also expired air, both orally and nasally. Okay? And they use a custom fitted face mask with separate valves to the nose and mouth, and they attached it to the flow meter in order to identify the air pressure and add resistance towards the airflow and also the difference in the breathing pattern in nose and mouth. So it provides an objectification of the ratio of oral to nasal airflow, and we can also determine which is more and which is less. So it is useful in identifying children who may have sleep disordered breathing and which can also lead to a range of health problems such as poor sleep quality, cognitive defects, and daytime sleepiness. So sleep disordered breathing may also be associated with other conditions like obesity, asthma, and allergies because whenever the patient is breathing through their mouth and at night when they do mouth breathing, it may invariably have a lot of effects on the internal like intraoral like gingivitis and infections associated with the tonsils. And other than that, it may also disturb their sleep pattern, which will lead to a lot of metabolic complications in their body. So during this test, we should analyze what is actually the problem with the child because we have a quantified data and then proceed to the treatment accordingly. Usually, mouth breathing is corrected with the help of a CPAP appliance that is called continuous positive airway pressure. It is a therapy wherein we give 100% pure oxygen to the patient for a particular period of time and it is followed through the months till the patient is good. And then, or it can also be followed by surgery if the patient is in a severe condition. So treatment, it may start from lifestyle modification up to surgery. It depends on the level of severity of the patient. So these NOT tests will give us an quantifiable value which will identify the patient's level of mouth breathing and also will help us to calculate the necessary action for them. So for the fourth question, bruxism bears which one of the following relationship to malocclusion? So what is bruxism? As we already discussed, bruxism is the clenching or the grinding of the teeth and it is usually associated in a psychological manner of the patient expressing such behavior. So malocclusion is the only cause of bruxism. So it's ruled out here. Malocclusion may be the cause of bruxism. So the key word here is maybe. Correction of occlusal discrepancy always eliminate bruxism. None of the above. So the answer is B. Malocclusion, it may be the cause. Sometimes an occlusal discrepancy of a malocclusion may be leading to the bruxism, but it is not always the cause and it can also be psychological. Yes, and bruxism is also called as a parafunctional habit by the grinding, clenching, or gnashing of the teeth. And it can have a range of cause, as I already mentioned, from stress, anxiety, medication to certain medical conditions. But whereas malocclusion is just a misalignment of teeth or jaws, and it may be one of the possible causes for bruxism, not the only cause for bruxism. So, while correcting occlusal discrepancy may help to alleviate some cases of bruxism, but it always doesn't eliminate the habit as such. So, malocclusion may be the cause, but it is not the only cause, and not all causes of cases of malocclusion lead to bruxism. It is not vice versa. And occlusal discrepancy correction may lead to relieving bruxism a bit, but since it's a parafunctional habit, it is mostly associated with the cause. In order to eliminate the habit, we have to identify the cause. Bluegrass appliance is designed to treat what? So there are four options here: tongue thrusting, mouth breathing, nail biting, and thumb sucking. So the answer is thumb sucking, but I'll just show you what a bluegrass appliance is. So it is basically a banded molars. Okay, it is connected with the roller appliance in the anterior region of the palate. So what will happen is that whenever a patient keeps his or her thumb inside this palate, it will roll it off. So they can't fix it there in order for the suction to create, thereby delineating a lot of process like constriction of maxilla, protrusion of the upper teeth, increasing the overjet, and lower incisor inclination and such. As we already discussed about thumb sucking pattern, thumb sucking's effect on the dental parameters, okay, of children. So this bluegrass appliance will help in eliminating the suction pressure created by pressing the thumb over the palate because it has a roller blade in it. It can also be used for tongue thrusting in certain ways. Okay, the tongue cannot go and protrude through the anterior region of the maxilla, and it will always be pushed behind. So majority of the case, the bluegrass appliance is given for thumb sucking, but it can also be used for tongue thrusting in a range. Yes. So we'll just discuss this. Biofeedback mechanism is used in the elimination is done. So what is a feedback mechanism? Generally, okay, feedback is something that after you perform a certain scenario or a certain procedure, the opposite party will give you a feedback of it. So one procedure should be done to receive a feedback. So that is how feedback works. And based on the feedback, the procedure can be altered either in a good way or in a better way. Okay. So similarly, biofeedback means it is monitoring the patient's particular habit and then giving a feedback with the help of which the procedure can be changed accordingly. So I'll be showing you a picture with which you can recognize it much easily. So it is done to eliminate which habit? Thumb sucking, tongue thrusting, mouth breathing, and lip sucking. So here we have to understand that this feedback mechanism means someone should monitor you. It is impossible for someone to monitor you 24/7. So it involves a certain a chip or a camera with which like they can monitor. So a chip or camera cannot be placed in the tongue or mouth or lip. So obviously it can be placed in thumb because it is somewhat outside the oral cavity. So the answer is thumb sucking. So sometimes it is given in the thumb region. So whenever the patient goes for thumb sucking, it will identify change in environment and thereby a feedback is created with which we exactly know how much time or duration the patient is having the habit and then we can later reduce it. Yes, so it can be used as a part of a comprehensive treatment plan to help children overcome the thumb sucking by providing them with a um, real-time information about the thumb sucking behavior. So the device monitors the child thumb sucking behavior and provides feedback in the form of visual or auditory signal when the child begins to suck the thumb. So sometimes it rings so that the child is aware and conscious about the thumb sucking habit and then suddenly stops. So in this way, it will help in the elimination of the habit. It can be an effective tool in the treatment of thumb sucking. It is not typically used to treat other habits like tongue thrusting, mouth breathing, and lip sucking. So, which of the following does not describe the action of crib during habit breaking? So, which habit are we trying to break here? A crib generally means it is placed inside the oral cavity, and crib means like a cage. So we are talking about either thumb sucking or tongue thrusting, right? So which of the following does not? So the key word here is not. Act as a reminder for the child, make habit unpleasant for the child, distributes the tongue pressure for the posterior segment, reinforces the suction force on the anterior segment. So the three A, B, C, it is associated towards habit breaking. So reinforces the suction force on the anterior segment makes no sense because we cannot do any suction force because of the crib. So the answer is D. So crib is something which looks like this, so that the patient cannot keep their tongue as well as the thumb over it, and um, be it may sometimes be hurtful for the patient. They may sometimes feel pain if they keep their thumb or tongue over it, and therefore it acts as a reminder therapy. So the vertical bars are designed to distribute the tongue pressure to the posterior segments of the mouth, because generally in thumb sucking or tongue thrusting, the tongue is usually focused on the anterior segment, right? And the posterior part is getting constricted. And we also have seen effects of posterior crossbite, wherein the maxilla is in and the mandible is out. So with the help of the tongue crib, it will delineate the pressure towards the posterior aspect so that we can avoid a posterior crossbite. It is worn for several months, and the child is monitored by the orthodontist to ensure that the habit is completely broken. So only after the habit is broken, the tongue crib is removed, and that is not removed completely. Initially, they'll be taking out 2 spikes, and then they'll be removing 2 more spikes. Okay, so that only when we are sure the habit is done, the tongue crib will be removed completely. And with this, we've come to the end of habits. So I'll just give a small recap. Basically, what habits have we seen? We've seen important factors about thumb sucking, tongue thrusting, mouth breathing. And with respect to mouth breathing, how it causes apneas, and what are the modes of quantifiable identification of mouth breathing. We've seen about snort test, rhinomanometry, and what is the possible treatment for mouth breathing. It can start from psychological evaluation to the CPAP, that is continuous partial airway pressure. And regarding thumb sucking, we've seen about what are the different grades of thumb sucking, and then how to prevent thumb sucking, and what are the effects of thumb sucking on the dental cavity, that is what it does to maxilla and mandible, and also with respect to tongue thrusting, what are its effects on the oral cavity. So with all this in mind, let us proceed to space maintenance now. If you have any question regarding habits, you can put in the comment section so that I can address it now. Okay, so I've not noticed any comments, so I'm proceeding with the space maintenance. The term space maintenance refers to the preservation of the space for the permanent tooth in a child's mouth, the preservation of total arch length of all the permanent teeth in the arch in a child's mouth, or the prevention of the mesial drift after the loss of the tooth. And I think the answer would be the preservation of the total arch length or all of the permanent teeth in the arch in a child's mouth. So the arch length is generally measured, okay, from the central point of the upper central incisors. From there, a line is drawn, and it will meet wherein the permanent molars distal aspect is drawn horizontally. So the line, vertical line from the tip of the central incisor to this horizontal line will be measured as the arch length. The space maintenance usually refers to the maintaining of the arch length in preserving the arch length or of all the permanent teeth in the arch in the child's mouth. So this is more suitable to the given question. So you will be always intrigued to go with the option all of the above, but since there is not an option here, the most relevant option would be this one. So it is a critical aspect of pediatric dentistry because we should always look out for the permanent teeth eruption and the exfoliation of a primary tooth in order to maintain the arch length and give space maintenance necessary. Whenever there is a premature exfoliation of a primary tooth and it will take a longer period of permanent tooth to come through the bone towards the oral cavity, then a space maintenance is definitely included in the patient's plan. It can either be functional, That is, a crown can be present there, or it can be non-functional, wherein just an acrylic layer is present in the area of the future position of the permanent tooth. So space maintenance are generally used to prevent complications or to prevent the further disalizations or further complicated procedures. They can typically be made up of either metal or acrylic, and it can also be fixed or removable based on the patient's competence. And the primary teeth are really crucial for maintaining the proper alignment and space required for the eruption of the permanent teeth. And premature losing of the primary teeth may always lead to the loss of arch length. So there are different types of space maintenance. Okay, give it. There are mainly two types. One is fixed and one is removable. It can either be metal or it can either be acrylic. These fixed space maintenance are generally cemented or bonded to the adjacent teeth, wherein the removable space maintenance can be taken out by the patient as such for cleaning and then put it back again. So coming to the indications, it is typically recommended when a premature exfoliation of the primary tooth, and they are commonly used when a primary incisor or a primary molar is lost. What are the benefits? It will prevent the future complicated dental movements which is required during an ortho treatment. And they also aid in maintaining the proper chewing function and speech development. Because if one side there is an exfoliation of a primary teeth and other side there is no exfoliation, then the patient may tend to chew more on one side, which may lead to an asymmetrical condition. So it will also avoid it going towards that direction. And it will also help in monitoring of the tooth eruption. So now we have seen about the space maintainers, why it is used, okay, and how it is used, what are the different types of space maintainers, and what are the indications of space maintainers and why it is necessary. So space maintainers are usually needed in the maxillary primary incisor area, mandibular primary incisor, or mandibular primary canine, mandibular primary second molar. So given the four options, you would feel that it would always be necessary in whatever case is needed, right? But most commonly it is associated with the mandibular primary second molar area, and because of the fact that though it comes later in the patient's mouth, but still it has the most caries development, and there will be an exfoliation common in this tooth. So the term space maintenance refers to the maintenance of the arch length of the permanent tooth on dentition. So yeah, as we already discussed the similar topic in the previous question. So the high yield fact is that the premature loss of primary teeth can occur due to various reasons, such as dental decay, trauma, or early extraction. So in all those cases, it is really necessary for us to go with the space maintenance. And it's recommended when there is a premature exfoliation, especially. So it can also help in preventing the need for extensive orthodontic treatment in the future and also avoiding the misalignment of the teeth. So coming to which of the following condition the space loss is most difficult to manage. So identify the question. There is a space which is lost, and in which area it is very difficult to manage. A 5-year-old child with the loss of a primary mandibular second molar, a 6-year-old child with the loss of primary mandibular first molar, a 9-year with the loss of maxillary first molar, a 10-year with the loss of primary maxillary second molar. So in this question, the important aspect is that they're asking which is difficult to manage. So you should identify the tooth eruption ages. So for example, here a 10-year-old, right? There she has a loss of a primary maxillary second molar. It is good in this age because in a year the premolar is going to come. So the premolar is now traveling towards its future position. So even its exfoliation won't matter so much because already there will be an excess space. A 9-year-old child also with the loss of permanent maxillary first molar, it will also be difficult because the permanent molar is itself is lost, but the second molar, right, it will come up in the age of 12 years, and when this is lost, there will be a mesial drift of the tooth. A 6-year-old with the loss of primary mandibular first molar. So the primary molar is gone, and she's only 6. Now coming to the first option, the 5-year-old child with the loss of primary mandibular second molar. So there is a lot of time for the permanent tooth to come to its position. So for minimum of 4-5 years, we have to maintain this space. And now with this in mind, we know which is very much crucial, right? It is option A. Yes. So the mandibular primary second molars or the last primary molars to erupt in the lower jaw. So these erupt around the age of 2.5 to 3 years and are usually lost around the age of 10. Because at 5 itself, she loses this tooth, which is supposed to go at 10-year-old. So we need at least a minimum of 7 years for it to be replaced by the permanent premolars. So for 7 years, we have to properly maintain the space, and that is really difficult. Or else there will be a mesial drift of the permanent first molar, which can result in inadequate arch length and thereby collapsing the arch, which may be asymmetrical from one segment to the other, and there will be a lot of problems. So space maintenance are particularly designed in all these cases to hold the space open until the permanent premolars come to its position. So the fact associated with this question is that mandibular primary second molars are the last primary molars to erupt in the lower jaw. So the premature exfoliation may mean to the mesial drifting of the permanent molar, which may collapse the arch length. And this space maintenance must be used in mandibular primary second molar area to prevent the space loss and maintain the arch length. So regular dental checkups should be done in order to identify these conditions. So coming to the next question, a space maintainer is least indicated for premature loss of. So it is see the question, there is least in it. Primary maxillary first molar, primary mandibular first molar, primary mandibular central incisor, and primary maxillary central incisor. So obviously it's maxillary central incisor because um, the permanent tooth bud first occurs in that area in order to replace it. So it is least indicated for a space maintainer to be there. Yes. So the condition in which the space loss is most difficult to manage was a 5-year-old with the second molar gone, right? So this will be the opposite of it, easier done. Because at the age of 2.5 to 3 years and are generally lost around the age of 10 to 12 years regarding the previous question. But in this question, least, which means the maxillary central incisors are the one of the permanent tooth to come early in the mouth, so it is not a problem. Yes. So I think they are saying the same thing again. So I have given the chart wherein to identify at what age each tooth erupts. So this is very important for you to answer all these questions with respect to space maintenance and to identify which is most important to deal with and which is very urgent. So usually remember all these things. So upper central incisors is 7 to 8, lateral is 8 to 9. So I usually remember in this way. So first lower central incisor comes in, so 6 to 7. And then lower lateral incisor is 7 to 8. Similarly, upper central comes in. So if you remember like this, which comes first and go till which comes last, it will be very easier for you to remember. For example, first is lower central incisor, and then lower lateral incisor and upper central incisor, then upper lateral incisor, and then lower canine. Okay. After lower canine, you go lower first, upper first premolar, lower first premolar, um, upper second premolar, lower second premolar, and then you go for upper canine. Only after the premolars, the upper canine comes, but in case of lower, it comes after the lower incisor. So, and then we go for the first molar, second molar, and third molar. For first molar, it will come in the same age as lower central incisors. Okay, so I'll just be very fast. Lower central incisor, lower lateral incisor, upper central incisor, upper lateral incisor, lower canine, lower first premolar, upper first premolar, lower second premolar, uh, upper canine and upper second premolar, then second molars and third molars. So the first molars will come in the stage of lower incisor. I think you got the gist. So you remember in whatever way you want. This is the way I remember it, and I hope it will be easy for you. During the eruption of lower lateral incisors, left primary canine is prematurely exfoliated. So what will be the line of treatment? So we just now saw when the lower lateral incisor was going to come. It was 7 to 8 years. So the left primary canine is prematurely exfoliated. Okay, so what will happen? No treatment, periodic observation, because the canine comes after it, right? 9 to 10 years. So we have 1 year time. Extraction of the right primary canine to prevent the midline shift. Move the left permanent lateral incisors towards the midline. Move the right permanent lateral incisors towards the midline. You're not going to touch the permanent incisor. So C and D are out. So the answer would be extraction of the right primary canine, because usually when there is a unilateral exfoliation, there is a tendency of the permanent tooth to move to the place when there is space. So when it does, then the midline will be shifted and it's very difficult to bring it back to its original position. So the answer would be extraction of right primary canine in order to prevent the midline deviation. Okay, yeah, as I said, it will lead to a mismatch between the upper and lower midline, which will be difficult to be treated. So the left primary canine is prematurely exfoliated, right, because of the eruption of lower incisor. So to prevent it, they'll immediately exfoliate the, remove the right primary canine, so that the midline discrepancy doesn't happen. When one primary canine is lost prematurely, it is imperative to maintain the midline. We just now discussed. Usually, when it comes to canine, it's very important that the midline topic should be in your mind. And the first line of action would be not periodic observation, but instead removing the opposite side deciduous tooth. Yes. So it is important to maintain the midline alignment for both aesthetic and functional reasons. Otherwise, there will be a mismatch between the maxilla and the mandible, and it is also imperative because one side of the arch will go towards one side wherein there is a exfoliation, and the space won't be enough for the permanent tooth to come there. So it will be leading to crowding. In order to prevent all that, always midline matching should be done whenever a permanent tooth is coming into place. Yes. So what will be the treatment options to maintain the midline? One can be removing the deciduous tooth, right? And the other can be putting a space maintainer in that area so that the permanent tooth doesn't drift towards the same side. And early intervention and timely treatment are very important in preventing the midline discrepancy. A 10-year-old patient has lower canines trying to erupt in the space insufficiency by 2 mm. The primary second molars are large and firmly in space. The first premolars are erupting. An acceptable preventive orthodontic procedure in this case. See, the question is beautifully arranged. Why? Because you have three key factors in the question. One is a 10-year-old patient. So, at 10 years, obviously the premolar is going to come. The second molar is going to be, or it is going to get worn off in a short duration. He has lower canines, which is trying to erupt with only 2 mm deficiency. So 2 mm is a very small number to be deficient with. And they've also mentioned first premolars are erupting. So it is going to come into the place of the deciduous molars. So what can be done? Extraction of primary second molars. So what will happen if you extract it? It's only 10 years. It will take 1 more year for the premolars to come. So this canine will come and completely occupy the area. There will be no space for the premolar to come in. Extraction of the first premolar, it's not even an answer. Disking of primary second molars and active space regainer. So though extraction of primary second molar is a good choice, but again you have to proceed with space maintenance for a long period of time for the premolar to come into space. Instead, if we go for disking of primary second molar, what is disking? Disking is nothing but interproximal reduction. It reduces 0.5 or 1 mm of each side of the tooth. That is the mesial and distal contact of the tooth. It reduces it so that we have enough space for the space deficiency by the canine. So the best option here would be disking of the primary second molar. Disking won't give you any sensitivity or any deficiency of the enamel. And that too, we are only disking the primary molars, which is going to fall off eventually in a period 1 year or 2. So it is perfectly normal to disk it rather than to remove it and proceed with space maintenance for a year or 2. The answer is C. Yeah, because as they've mentioned, the primary second molars are large. So we can obviously disk it to gain the space for the canine. I've mentioned it. And this is also a conservative approach. We are not worrying the patient with respect to placing the space maintainer for a really long period of time. So disking and interproximal reduction is a preventive orthodontic procedure that involves removing a small amount of tooth structure from the adjacent teeth. And it also provides an additional space. And yeah, we've created space so that the canine will also come into its place. So that's a very beautiful question with a nice framework. So always give importance to the ear of the child whenever they mention it, and also think about the eruption sequence of the tooth. So when you correlate both, then you'll get a perfect idea on how to proceed with the treatment. So in an 8-year-old child, there is an insufficient space in the upper anterior segment for the upper permanent lateral incisors to erupt. So there is no enough space here. And 8 year, it should have come into the occlusion, right? 7 to 8 and 8 to 9. Okay, within 9 years, it has to come. The treatment is disc the proximal surface of maxillary incisor, disc the deciduous canines and the first molars, extract the deciduous first molars, no treatment required but observe. So no treatment required but observe is really wrong, because you need the child is coming at a suitable age for the permanent tooth eruption. So no treatment required is wrong. Extract the deciduous first molar. It will be giving a large amount of space, and the patient is only 8-year-old. He has to wait for a minimum of 3-4 years for the premolars to erupt. So that is also wrong. So we are towards disking the proximal surface of maxillary incisors or deciduous canines and first molars. So usually we disc only the primary tooth whenever we get a chance, because we don't want to disturb the permanent tooth which has just entered into the oral cavity and it's going to be there for a really long period of time. So always prefer disking the deciduous tooth. Yeah, I've explained all the things that is given here. So yeah. Yeah. A dentist performed a restorative procedure in a 11-year-old child and found that the primary molars were in various stages of exfoliation with the slight anterior crowding present. His next appointment should be. So imagine it is a 11-year-old child. So premolars are almost coming to the occlusion. And there is a slight anterior crowding. After 3 months for observation, 6 months for recall checkup after 1 year, or when all the permanent teeth erupt. So usually you would have known a term called leeway space. Okay, what that means is that our primary or deciduous tooth in the posterior segment occupy a larger area when compared to its permanent successors. So there will be a space difference which can be adjusted for the correction of the crowding. So the answer here would be after 3 months of observation. We have to be very closely watching the patient, because whenever the primary molar exfoliates, the premolars can come to its position and then we can adjust the crowding accordingly. So they've just given it should be scheduled for 3 months after observation. Slight anterior crowding indicates that there may be insufficient space for the eruption of permanent teeth, which can also lead to the malocclusion. So by scheduling a follow-up appointment very closely very closely with the duration, we can identify when it exfoliates and how much space is actually is present and how much is required for the correction of the tooth movement. A timely evaluation is really necessary. So close monitoring during the transitional phase also will allow a better understanding by the dentist. So yeah, what you see in the screen is a procedure of doing a interproximal reduction. So they can also be done with strips. There will be diamond coating in each strip, and it will be taken between the tooth so as to it will reduce some amount of tooth surface. Or else we can also use a contra-angle handpiece with the interproximal reduction bus or wheel burr, and we can just go into it. It should be done in a 90-degree angulation to the flat occlusal plane, and with that, tooth reduction interproximal reduction is done. So coming to the next question, the permanent maxillary first molar of an 8-year-old child is to be extracted because of caries. The case can be maintained to prevent malocclusion. So what are they saying? It's an 8-year-old child, but it is a permanent maxillary first molar. And since it's an 8-year, the second molar has not erupted yet. And they are already decided that it has to be maintained. Okay. So what would you think? Obviously, in the question, it is given maintenance. So we are placing a space maintainer. You do not need an option as an answer for that. Surgically repositioning the second molar, which will be very tedious because it is still developing. We can't take it out and position it. It's only 8-year-old child. Let second molar erupt and drift easily to close the space, or extract first molar on the other side to prevent midline shifting. So midline shifting usually is associated with canines and premolars because they are very close to the midline. With respect to molars, here the very feasible and the best option will be second molar erupting and drifting mesially to close the space. Though maxillary permanent first molar plays an important role, but such an early age it is exfoliated or it is to be extracted, then we can guide a second molar to come into its place by placing certain space maintainer as a guide initially and then bringing it to the first molar place. So it is also very important to closely monitor it and position of second molar during the follow-up visits to ensure it is aligning properly and closing the space efficiently. So the important facts here is that premature extraction of permanent teeth can lead to space loss and subsequent malocclusion. We have to plan accordingly before extraction of any permanent teeth so that the malocclusion is minimized to a maximum extent and also midline shift is not there. Mesial drift, there is an inherent ability of all the tooth to have a mesial drift towards the extraction site. So we can harness that force and then bring the second molar to the position of the first molar. Yeah, and early intervention and appropriate management is highly recommended because what will happen if the second molar is not brought to the place of the first molar, then this happens. The bony ridge of the first molar will recede down, okay, and because no tooth is opposite to the upper first molar, right? It'll try to drop down. It will push the second molar, which will again in turn mesial in movement and which will also make the upper second molar to come down. So it will lead to a series of unfortunate events which will result in severe malocclusion and the patient eventually can't bite at all because of the constant hit with the molars. So it's very essential to replace the permanent tooth which is being prematurely exfoliated or extracted. A patient aged 9 attends your clinic. He has a class 1 incisor relation. Upper and lower incisors show slight crowding. Right upper and left lower primary first molars are recently extracted due to caries. The line of treatment would be, see, uh, sorry, what have we pressed? Yeah, done. So see, right upper and left lower primary first molars. It is primary first molars, so it's closer to the midline when compared to the permanent first molar. And also, they have given two opposite sides. So what will happen? The patient is 9 years old, so obviously premolar is going to come. So we need to extract the upper left and right lower primary first molars to relieve the crowding. We can use that space for relieving of the crowding, and there will be enough space for the premolar to come into the occlusion as well. Yes, the answer is right. The same thing. Close monitoring of eruption is obviously needed. If the ears are lost due to the caries at 8 years in a crowded mouth, 5 will be probably. What will happen? What are ears? Deciduous, second deciduous molars, okay? If they are lost due to the caries at 8 years. So the second premolar, it will take a lot of time to come to the oral cavity. So obviously they won't be impacted because they are lost, right? There will be certain area present. So it will be deflected palatally. See in this area, the position of the bud is more palatal and therefore when it comes into the occlusion, it is deflected more palatal. The palatal deflection is the deviation of tooth eruption towards the palate or the lingual side. In crowded mouths, because of lack of adequate space, usually it will go to the palatal side and it disrupts the natural sequence of tooth eruption. It can also lead to the deviation of the part. That's where impaction comes in. So usually remember the lower premolars will always deflect palatally or lingually whenever there is a lack of space. Space management in the case of a loss of primary first molar in a 10-year-old girl. So the key factors here are 10-year-old girl and primary first molar. So it is going to get replaced by the premolar, which is going to be very short. So the answer would be no treatment and radiographic observation. Because as I already suggested, the premolar is almost in the almost coming to the occlusion or almost piercing of the oral mucosa. So at that time, it won't be necessary to give a space maintainer appliance. So no treatment and radiographic observation. You can do this fast only when you are thorough with respect to the chronological period of tooth and also when you pay close attention to the question. Yes, same thing. No treatment and radiographic because for close monitoring of the eruption of permanent teeth. As already said, everything is the same. So coming to the next question. Girl of 10 years reports for examination immediately after the exfoliation of second primary molar. She has full complement set of teeth in a good occlusion. The line of treatment will be no treatment, only observation. Place a lingual arch space maintainer. Place a distal shoe space after the radiographic finding. Treatment depends on the radiographic finding. So here, 10-year-old, but the premolar has not erupted yet, but second premolar will take time to erupt. So she at least has 2 years time period. What will be the given cause? It depends on the radiological finding. If the premolar is in line with its eruption, then it will be a very fair method to leave it as such. If not, it will require more time. Okay, then we have to go with the space maintenance. So generally, you can go with placing a lingual arch space maintainer. Okay, but in this MCQ, they have already given an even better answer. Like it depends on the radiographic findings. So we can go with the option D. Because it is important to evaluate the dental development. The dental age is very important. So you all know, right? The dental age is different from the chronological age. Chronological age is when a patient comes and says, "I'm this year old. I was born at this date." Dental age will be different. So some people will be late maturers and some would be early. So in order to utilize that harness the growth, we need to understand the dental age and development using radiograph. So that the radiographs is very important when you take decision regarding space maintenance or whether you're waiting and monitoring the condition for treatment. So it really matters. Yes. So radiographic examination plays a crucial role in the dental development and also the eruption pattern. Immediate treatment may not be necessary if the dental development and occlusion are normal. Another important word, key word in the question was her complementary occlusion was completely normal. So we can go for radiographic examination and wait for it to erupt completely. So a lingual arch can be considered if space loss was a concern. So till now there is not a concern because they've given in the question she has good complementary occlusion. Which of the following factors are important when space maintenance is considered after the ultimate loss of the primary teeth? So chronological age, skeletal age, dental age, and biological age. I was just discussing this now. It's dental age of the patient, as we already discussed. So when each tooth is coming into the occlusion, we must know. Accordingly, we can answer a lot of questions pertaining to the space maintenance topic. Yeah, we discussed this now. So, yeah, basic idea is that you should know about the chronological and dental age, and we should identify the maturity index of the patient. And also, we should know which tooth is erupting and what is the actual age of the patient, so that we can correlate and decide whether an intervention is necessary or we can wait. Or a radiological examination will be the key to the particular scenario. So it's always the best answer wins. Okay, it is not a particular answer for all the question. Always see each answer, identify with it, and decide which is the best for the given question. There can be two best answers, but decide which is the perfect answer for the question and then go with it. So, most important factor in planning for a space maintenance: age of the child, amount of the bone covering the erupting permanent tooth, stages of development of permanent tooth, and economical factors. Obviously, the answer is amount of bone. I think you should have known about NOLA stages. So there are 9 NOLA stages starting from 0. 0 means no calcification. 1 is presence of calcification, and then it grows. 1/3 of the crown completed, 2/3 crown completed, crown almost completed, and crown completed. And then it starts with root. 1/3 of the root completed, 2/3 completed, root almost completed, and root completion done, root completion with apex closure. So there are at least 9 stages in NOLA with which it can determine whether the permanent tooth is going into occlusion based on the bone covering. So this is also one of the important points you should learn about NOLA stages. So the bone covering the erupting permanent tooth is very important factor in planning for the space maintenance. Because it denotes the eruption process and osseous process. Eruption process is the emergence into the oral cavity. Osseous development is during the different stages of tooth development. The surrounding bone also undergoes changes. So when it undergoes changes, there will be a thinning of bone so that the tooth will erupt past it into the oral cavity. And long-term success, a well-formed space maintainer with adequate bone coverage would increase the chances of a successful outcome because it will prevent the space, it will provide the space for the permanent tooth and preventing potential orthodontic complications in the future. Radiographic assessment is also helpful because it knows exactly where the tooth is and gives us the duration to calculate for the space maintainer and to decide whether it can be a functional or a non-functional one. So basically, functional means it will have a tooth acrylic over the top. Non-functional means it will be flat. So the next question, what is the amount of bone through which a normal tooth erupts in 4 to 5 months? So there is a formula here. Depending on the amount of bone, we can identify how much months it will be taking for the permanent tooth to come into occlusion. So here it is 4 to 5 months. So the answer would be 1 mm. It will take 4 to 5 months for the permanent tooth to cross 1 mm of bone and then coming out. So accordingly, we can calculate how much of bone thickness is present during a radiographic finding. Yeah. Why that happens? So the bone will undergo a resorption process, which is very slow, and it will help in the permanent tooth to come up, that is migrate up. That is called as the rate of eruption. So the rate of tooth eruption varies depending on the tooth type and individual factors. On an average, a tooth can erupt approximately 1 mm per month. So over a period of 4 to 5 months, the normal tooth typically transfers a distance of 4 to 5 months. But it has a lot of factors involved, and sometimes it will take a lot of time for the tooth to even cross 1 mm. So the given action option is that 1 mm it will take around 4 to 5 months. Supporting structures should also be in a good condition because if it is a periodontally compromised case, then that can't be an issue. It will take a longer period of the time for the tooth to come out. The correct answer is option B, 1 mm. Average rate of tooth eruption and provides an insight into the amount of bone that undergoes resorption and remodeling during a 4 to 5 month period of the tooth eruption. So when a primary lower first and second molars are lost in an 8-year-old patient, so this is 8 years, so it will take almost 4 years or 5 years for the tooth to come into the occlusion. So the space is best maintained by obviously a space maintainer. So it can be a bilateral non-functional space maintainer. So as I've already said, the one with the tooth is a functional one and the one with an acrylic plate is a non-functional one. So bilateral non-functional space maintainers are the best choice because they do not exert any active force on the remaining teeth and they consist on bands or crowns on adjacent teeth connected by wire or bar and spanning the edentulous area. Preservation of space. So bilateral non-functional, they also maintain the space bilaterally, preventing the mesial migration of permanent tooth. So that when the permanent premolar comes, they'll have enough space for them to erupt properly. That's the most important aspect of a space maintainer. Functional appliances such as herbs or twin block are also used to correct skeletal discrepancies and alter the jaw relationship, but they're not primarily indicated for it because they don't exactly maintain the space, but in turn they make jaw changes, jaw modifications. So they're not generally indicated for space maintenance. Band and loop space maintainers are nothing but a very simple mechanism to maintain it. They'll just have a loop area in the area of the future eruption of permanent tooth, and the band would be on the adjacent. So it will help in the correction of the permanent molar eruption. Distal shoe appliance is contraindicated. And so first for that you need to understand what a distal shoe is, and with that in mind, it is all of the above. Yeah. Distal shoe is something which there is a band which is covering the tooth, or it may be a crown associated with that, and there will be a loop. At the end of the loop, there will be a hook. So this hook will help in the eruption of an adjacent tooth so that it doesn't easily drift into the extraction space. See, it is guiding the adjacent tooth to erupt in a normal way rather than in a mesial drift. So it is generally contraindicated because there is a metal extension that guides the eruption of permanent molar into its permanent position. It is going into the gingiva, right? So mostly it is associated with some infection rates. So it is contraindicated in a majority of the blood-associated diseases, congenital heart diseases, and also other hemophilia, and other conditions and risk of complications. If at all the patient is not having any of these complications, then the distal shoe space maintainer is a good choice for preventing a mesial drift of the second molars. In a case with premature loss of second deciduous molar before the eruption of first permanent molar, which of the following space maintainer is indicated? So here, cantilever type is indicated because there is a loss of second deciduous molar, and the first permanent molar will obviously try to come into its place. But if it comes, then the arch length will be gone. Premolar won't have space, and there will be sufficient crowding in the anterior region, which we do not want at all. So we have to bilaterally maintain the position of the permanent molar so that cantilever type, that is, it will have a U-shaped loop before the molar so that it can't travel past it. It will be positioned in the same area, and the remaining arch length will be utilized for the eruption of the permanent premolars in that area. So cantilever type is the best choice for this kind of thing. Yeah. So fixed lingual arch is also a space maintainer when multiple teeth is lost, so that it will be getting fixed in the lingual part, and there will be space for the permanent tooth to come up. The band and bar type space maintainer is commonly used for single tooth loss in the posterior region. Okay, so it is not bilateral, it is single. So for that, band and bar type can be used. For lingual arch type, as we discussed earlier, multiple tooth loss can be used. For cantilever, it's like bilaterally a single tooth has been lost, means you can go with cantilever type space. Broken stress type means it's used in cases where the primary canine is lost prematurely. It consists of a wire around the primary canine and extends across the edentulous area, maintaining the space and guiding the eruption of the permanent canine. So in the given scenario, the best case is the cantilever type. Main space maintainer represents which of the following types of space maintenance? So it can either be a non-functional band and loop, non-functional crown and loop, functional cantilever, and functional crown and grip. So the answer is non-functional band and loop. Main space maintainer. So a lot of space maintainers are available, and now we've discussed about some like cantilever, distal shoe space maintainer, and functional and non-functional. So main space maintenance is a specific one which represents the non-functional band and loop. Yeah. The same thing is being repeated here. So it is nothing but a passive appliance with when a single primary molar is lost prematurely. So they have a stainless steel band and crown placed on the adjacent tooth and loop extending into the edentulous space without any active force applied. So when there is a passive appliance, then we go for main space maintainer appliance, which is also called as non-functional band and loop. Yeah. So all that describes the space maintenance, which we've already discussed. So Jennifer at 4 years got her lower second molar extracted due to caries. The possible line of treatment is, so she's only 4 years, but got her lower second molar extracted. So we need to maintain that space for a really long period of time, and hence definitely no active treatment necessary is wrong. She can either go for a distal shoe space maintainer or a band and loop and a removable partial denture. Answer will be distal spatial maintainer, because it will also help in guiding of her second permanent molar or first permanent molar into its position with the help of its metal which is going into the gingiva. So it is designed to maintain the space and also guide the eruption of the first molar. It can distal shoe space maintainer can be used in cases where there is a premature loss of primary tooth, and when there is no permanent successor tooth present, that is, which is very early for the permanent tooth to be present, consists of a wire which is inserted in the distal end of the primary first molar, extending under the gum tissue in order to bring the permanent molar into its correct position. So it also helps to ensure that there is sufficient space for the permanent tooth to erupt in its correct position. So the eruption of permanent first molar usually occurs around the age of 6 to 7 years. So it is good to give this sometimes. The main reasoning for replacing the premature loss of primary anterior teeth. So why are we replacing the primary anterior teeth? Mainly because of speech and aesthetics. Because speech development plays a major role during the early part of life, and the patients should be able to provide with all speech regulations of all the consonants, sibilants, and vowels. So speech is really an important factor when it comes to replacement of the early exfoliation of primary teeth. Which of the following cannot act as a space maintainer? A well-restored tooth, lingual arch, Nance holding arch, and maxillary expansion device. So a restored tooth can also act as a space maintainer. A lingual arch, it holds the position of the tooth. A Nance holding arch is also holding the position of an arch. But maxillary expansion device, it just expands the maxilla, so it can't account as a space maintainer. Yeah, we just discussed about all the things. Which of the following can be used as a spaced maintainer in the mandibular arch of mixed dentition period following the loss of primary molars? So, in the lower, the primary molars is lost. So, which can be used? Nance holding arch is generally preferred for upper. Passive lingual arch, pen and tube, and all of the above. So, passive lingual arch will be the best choice because, as we've already seen in lingual arch, right? Even when there is multiple loss of teeth, it still maintains the arch length by giving a loop before the molar. So some of the factors that nouns holding arch is a fixed space maintainer used to the upper arch, and the button is connected bilaterally. The bands and cemented on the first permanent molar. Passive lingual arch, it consists of a wire which is bonded on the lingual surface of the mandibular molars and extending anteriorly to prevent the mesial migration of the posterior. Pin and tube is another type of fixed space maintainer, but it is typically used in the upper arch rather than the mandibular arch. And all of the work cannot be used because pin and tube and Nance holding arch accounts only for the upper arch. So the last question of the day. No, I think we have some more questions. All of the following are true of band and loop space maintainer except. So a band and loop space maintainer, everything is true, only one is not true. Non-functional, requires less chair side time, removed and polished every year, prevents over eruption of the opposite. So it doesn't prevent over eruption because it is not even associated with the opposite teeth. Whenever there is an empty space here, opposite tooth should over erupt. So it is not associated with that. But still, it is true when it is considered the fact that it is non-functional and requires less chair cycle, and it is removed and polished every year. Yeah, it is because non-functional means it doesn't have a function or it doesn't provide a function, right? It's just plain. And it also requires less chassis time because when compared to other retainers, it's only a 1 year own service procedure wherein we polish and replace it. Yeah. So a disadvantage of removable space maintainer, the difficulty in maintaining a vertical height, not aesthetic, difficult to clean, may not be worn by the patient. So the last option is definitely right. Whenever you're planning to give a removable space maintainer, the compatibility issue of the patient should be checked. Only if the patient is wearing it regularly and has a habit of wearing appliance regularly, we can give it to them. That will prove to be the major factor. So they cannot be any difficulty in maintaining the vertical height if the patient is constantly using it. Not aesthetic, it can still be aesthetic because the given space maintainer can be aesthetic, and from outside point of view, it cannot be seen as an artificial one, but instead it provides a functional as well as aesthetic result. Not wearing it properly is the most suitable answer in this question. All are advantages of removable space maintenance except easy to clean, permit maintenance of proper oral hygiene, they maintain vertical dimension, band construction is necessary. So the answer is advantages and except. So the answer is band construction is necessary is not an advantage. Yes. Removable are dental appliances that can be taken out by the patient, and some facts related to that is it is definitely easy to clean because it is removable. The patient can clean it thoroughly, and because they can remove it, they can maintain the oral hygiene properly, and it also maintains the vertical dimension because it also ensures the proper alignment of the tooth. But band construction is necessary is actually incorrect because they do not require any band construction. In fact, this most commonly associated with this fixed space maintainer rather than removable space maintenance. Which of the following is recommended for bilateral premature exfoliation of the mandibular canine? So the mandibular canine is bilaterally exfoliated. So which will be required? Nance appliances for upper arch. We have lingual arch, band and loop, and distal shoe appliance. So I would go with lingual arch because in lingual arch we can identify a bilateral premature exfoliation, and also it is easier to give, and it has a loop before the molars. Yes. Lingual is the best. Standard loop would not be there because it can't be given bilaterally, separately, and separately. It is associated with a single tooth loss, and distal short planes mostly is associated with the molars, early eruption of the or premature loss of the first permanent molars. The best space maintainer for the early loss of upper of a developmental process, not the result of pathology. Primary incisors is the pin and tube maintainer because. So they're asking for the best space maintainer for primary incisor is pin and tube, and we have to reason it. It is aesthetically acceptable. It does not injure the upper lip. It is easy to fabricate, and it allows the lateral growth of the bone. So the answer would be D. Why? The pin and tube space maintainer is actually a fixed appliance. It is used to maintain the space following the premature loss of the primary incisors. And why it is used? Because it is actually aesthetically acceptable. It is blending with the natural tooth and it does not injure the upper lip. Okay? It doesn't even cause any damage to it. It is very easy to fabricate. It involves just an insertion of pin on the parietal side of the primary tooth and attaching tube to the adjacent tooth for stability. It's very simple. And the key advantage of pin and tube space maintainer is that it is the best choice for early loss of upper primary incisor because of a developmental process. It allows the lateral growth of bone as well. It doesn't prevent it. So, based on the factors like location of missing tooth, age of the patient, and specific dental condition, it is calculated. So the last question, yes. A mandibular lingual holding arch with loops mesial to each molar band is used in children for regaining of space. So sometimes what happens is that the U loop is activated, and because of the intrinsic potential of the material, it will try to push the molars behind a bit. So in that way, it will regain the space. So space maintenance and space regaining is totally different. We want to regain the space which is already being utilized by the mesial root of permanent molar. We have to incorporate some active component. It can't be passive. We have to religiously distalize the particular tooth because it has come into and it has occupied the space, right? So space regaining is a separate terminology, and you should always be careful to differentiate between space maintaining and space regaining. Here, a U loop is given means it is compressed. So what will happen when it tries to relax? It will push the molar behind and thereby getting enough space for the permanent premolars. That is the condition here. Placement. Correction of distally tilted molars. The mandibular lingual holding arch with loops is not specifically designed for the correction of distally tilted molars. Its main purpose is only to regain the space rather than correcting the tooth angulation. So yes, with this we come to the end of 1038 questions. And if you have any doubts regarding the things we discussed today, let me know and put up in the comment box whether you have any questions or if you have any feedback regarding the lecture, kindly give that also. And thank you for this information and hope to see you soon. Bye.